When I'm looking at US clinical experience, when I'm sitting on an interview or sitting on the rank order list meeting and things like that, we start by assessing where has the student done their US clinical experience, right? We want to make sure they've done it in an institution which has some repute, where we can trust their assessment, right? A lot of students, go to private practices, go to private hospitals, work with attendings who have no academic background and things like that. And that's kind of frowned upon in a sense because we really can't trust those letters of recommendation and things like that. So we really look at the institution to start off with. I think that's one of the biggest keys when we look at US clinical experience. The other thing is we look to see in what capacity the student has worked. Is it an observership? Is it a fourth year clinical, like a fourth year medical student? Or is it like a JI, which is like a junior intern? So your letter of recommendation or even your description of the rotation should definitely mention in what capacity you worked, a fourth year medical student or a GI, because that again is a rotation that we take more seriously than say an observership, right? So that's something we definitely look at. The other thing is we look to see who's given you your letter of recommendation. What's the role of the faculty? Now, we obviously trust a faculty who's been in a residency program, who's worked with fellows a little bit more, right? Because we feel like they can better assess a resident. So we look for someone who's faculty, someone who's worked with residents or fellows, someone who's in a leadership role, like say a director, an assistant program director, a program director. Obviously, we look at those kind of faculty with more, they look at their assessment with deeper value. And then the other thing is there are a lot of faculty who sit on what we call clinical core competency meetings. So when you're in a residency or fellowship, we have what is called a clinical core competency committee, where we sit every 6 months and evaluate a resident or evaluate a fellow. So some faculty who've been part of clinical core competency meetings or clinical core competency discussions, those kind of bring more value to what we would, look at in their letter of recommendation. The other thing is we look at the setting you worked in. Now, in general, I'll tell you in internal medicine, we're a little more concerned about how you're going to behave or how you're going to perform on the inpatient setting. Now, this is a family medicine residency, then maybe we kind of looking at more your performance in the outpatient setting. So we definitely want your letter of recommendation to reflect on what inpatient work you've done. And ideally, your rotations that are more inpatient heavy, I think we look at more favorably. So that's something else that we look at with regard to letters of recommendation. And then the other thing is we look to see how strong your letter of recommendation is. We want to make sure it's not a generic letter where they just say that, you came, you worked hard, you observed, everyone liked you on the team and things like that. We want a letter where we have more specific examples. Like the attending says, so-and-so came in, he took care of 2 patients. One patient had hemolytic anemia. He took a very good history. He followed up on these patients. He followed up on these patients' labs. He came up with a plan. So that tells us that the attending has observed you more closely. And it does give you some kind of something to illustrate how you performed. So I think those are really important considerations that we look for in US clinical experience.
Thank you so much for watching. We hope that video provided valuable insights for your journey. Don't forget to subscribe to our YouTube channel and follow us on Instagram and Twitter. And check out our website for details on how we can guide you to a successful match.